Hello, and welcome to the CAP Today webinar for April 25th, 2018. Today's webinar is entitled Fecal Matters, Molecular GI Testing, an Approach Based on Clinical Guidelines. Our webinar today is made possible by a special educational grant from Luminex, and we're very grateful to them for their special grant. Of course, I'm Bob McGonigal. I'm the publisher of CAP Today, and as usual, I'll be your moderator for this CAP Today commercial webinar. And after our formal presentations, I'll lead a Q&A session where you can ask your questions, and we'll look at your comments. Our speakers today, and I'll introduce them in greater detail right before each one speaks. Our speakers today are Dr. Daniel Rhoads of University Hospital at Cleveland Medical Center and Dr. Jose Alexander of Florida Hospital. But before we go right into the formal presentations, I want to share some housekeeping tips and hints with you. First, I recommend that many of you refresh your browser. This will help keep the optimal syncing with the slides and the audio. You'll be listening primarily today through your computer speakers, where of course you'll also be seeing the slides. Should you have a problem, we have live operators and technical help standing by to help you, so you can call for support in the number that you see there, 888-364-8804. At the bottom of your screen, you'll see a box underneath the slide labeled Q&A. And at any time today, you can type questions and comments into that box. That's going to be your mechanism for asking questions or making comments. We will not have an open phone question session. We never do. I want you also to understand that this webinar will be archived at captodayonline.com. That will be up with full slides and audio in about 5 to 7 days. Finally, it's important that you understand once again that this is a commercial webinar made possible by a special educational grant from Luminex. CAP Today does not endorse any products or services that may be named within today's webinar. Any comments that I myself may make are purely personal and not to be taken as policy of the CAP Today or the College of American Pathologists. So with that, I'd like to introduce our first speaker. Dr. Daniel Rhoads is a pathologist. He trained in clinical pathology at UPMC, and at the Cleveland Clinic he did a medical microbiology fellowship. He's currently the Associate Director of Microbiology at Case Western Reserve, their university hospitals, and the Cleveland Medical Center. And I will now invite Dr. Rhoads to begin his presentation. Dr. Rhoads.
Thank you, Bob. Good morning and good afternoon. I'm going to be touching on molecular testing for enteric pathogens. We're going to talk about guidelines and clinical practice. My goal for you is to be able to review the common causes of clinical presentations of acute gastroenteritis and recognize some of the recently published IDSA guidelines and the recommendations for diagnostic testing in acute gastroenteritis. So first, let's talk about common causes. This is a motivational slide to help to encourage you never to be tempted to eat a rare turkey burger. There's good reason that we cook our poultry thoroughly, and that's because a lot of it's contaminated straight from the supermarket with salmonella. And that's where a lot of these bacterial pathogens come from. A lot of them are foodborne, but some are also transmitted person to person. The CDC now tracks these person-to-person transmissions, and here's a report from a few years ago, and you can see on that left-hand bar there that a large majority of the person-to-person transmission of acute gastroenteritis can be attributed to norovirus. Norovirus is maybe not dear to my heart, but is near to me because it was originally called the Norwalk agent, and Norwalk is a short-hour drive from where I am currently in Cleveland. This quote at the top of the page is from a journal article. It says, one of the outbreaks, is the outbreaks of the Norwalk agent, now called norovirus, took place in an elementary school in Norwalk, Ohio, in October of '68, and it was investigated by the CDC. During that 2-day period, half of the students and teachers developed a gastrointestinal illness, which was described as winter vomiting disease. Here you can see the onset of norovirus throughout the year, and you can see why winter is attributed to the winter vomiting disease. It's much more prevalent in the winter time, December, January, February. Thankfully, we're getting past that winter vomiting illness season. CDC has special recommendations for healthcare workers when we work with people who have norovirus. And our infection control practitioners in the hospital take note when somebody's diagnosed with norovirus infection, because the CDC recommends not just using the foam in, foam out hand sanitizers, but to actually wash our hands, similar to what we do when someone has a C. difficile infection. If we focus in on some of the common causes of infectious gastroenteritis, norovirus, salmonella, and shigella, you can see that diarrhea is a common theme, which doesn't surprise any of us, but some of the other symptoms and signs are a little varied. So norovirus, again, the winter vomiting disease, you can see is the winner when it comes to inducing vomiting in its victims, whereas salmonella and shigella, it occurs less often. Salmonella and shigella, however, often have fever associated with them, but you can see this is just over half the time. And the prevalence, or the incidence of norovirus is much greater than salmonella and shigella, so if you're a physician seeing patients and they have gastroenteritis and they have fever, most of the time, even though it's a minority percentage-wise in the patients who have norovirus, in absolute numbers, most of the patients who have acute gastroenteritis and fever are going to have norovirus and not salmonella and shigella. I'm going to take a couple minutes and talk to you about our practice here at university hospitals, and then I'm going to talk about the IDSA guidelines. So our laboratory serves about 12 acute care hospitals and a lot of outpatients. We do more than 2,000 urine cultures a week, about more than 200 blood cultures a day, and we test about 12 stool pathogen panels a day using the Luminex Verigene system. We recently got some new equipment. These are our new blood culture instruments. And for about 2 years, we've been using BD Keystra Total Lab Automation for bacteriology. Now, on that system, we put urine cultures, respiratory cultures, positive blood cultures, miscellaneous cultures, but not stool cultures. We no longer routinely perform stool cultures. Back when we did, this is what we used, which should probably be familiar to you. We use our Hector enteric for Salmonella shigella, our Sorbitol McConkey for O157H7 E. coli, CIN for Yersinia, TCBS for Vibrio, then a McConkey and a Campi plate for Campylobacter, incubated at 42. Then you can throw in a Shigatoxin assay to pick up the non-O157H7 Shigatoxin-producing E. coli, and then maybe a rotavirus for good measure. Now what we do, we don't do those. Now routinely, our routine test for testing for infectious gastroenteritis is the Verigene system, where we test for all of those things, plus we get norovirus. And our infection control practitioners are excited that we now report on norovirus, because the majority of infectious gastroenteritis is due to norovirus more so than any of these other agents. And like I mentioned earlier, infection control adds additional precautions if this is an inpatient to help prevent the spread of norovirus within the hospital. This is a slide of the results from here at UH last winter and this most recent winter. So the winter of 16-17, we were still culturing, and this last winter we switched over to Verigene. And you can see that our positivity rates were similar for the bacterial pathogens, and then you can see 8% of our cultures or our specimens were positive for norovirus this season, whereas we weren't previously testing for that. Okay, now let's talk for a few minutes about the IDSA's new guidelines. These are freely available online. I encourage all of you to Google them, find them, read them in your leisure. And I want to just mention what the IDSA is and what the practice guidelines are. So the IDSA is the Infectious Diseases Society of America. It represents physicians, scientists, and other healthcare professionals who specialize in infectious diseases. And practice guidelines, they didn't just make up this word, there's a definition. Practice guidelines are systematically developed statements to assist practitioners and patients in making decisions about appropriate health care for specific clinical circumstances. And then there are attributes that describe good guidelines, how valid they are, how reliable they are, how clear they are, how flexible they are, and how much evidence there is to support them. The IDSA guidelines on acute gastroenteritis are divided up into several sections. Because this is a laboratory seminar and I work in the laboratory, I'm going to focus on the diagnostic section. But there are lots of other sections if you're interested in exploring things like empiric therapy and those such things. In the diagnostic section, they pose a few questions and then answers to these questions. Questions include, what's the optimal specimen type? When should C. difficile testing be performed? Which pathogens should be considered and which tests will aid in identification? Which tests should be done when suspecting bacteremia in a patient with gastroenteritis? What's the clinical relevance of ancillary testing like fecal inflammatory markers? When should non-microbiological tests be performed? And what follow-up testing should be performed? Because of time, I'm not going to touch it all in these last 3 points, but for the remainder of my time, I'm going to talk on these top 4 points. So first, the optimal specimen type. This should not surprise anybody. It is a diarrhea stool sample that takes the shape of its container. For detection of bacterial infections, if a timely diarrheal stool sample cannot be collected, a rectal swab may be used. The recommendation for that, using a rectal swab, the recommendation is weak and the quality of evidence is low. Molecular techniques, they point out, generally are more sensitive and less dependent than culture on the quality of the specimen. The next question is, when should C. diff testing be performed? As you know, this is a hot topic. Testing may be considered for C. diff in people greater than 2 years of age who have a history of diarrhea following antimicrobial use and in people with healthcare-associated diarrhea. The strength of the recommendation is weak, but the evidence is high. Now, we could talk for hours about C. diff testing and algorithms and patient presentations, and the IDSA actually put together a completely separate guideline for C. diff, which was published more recently, actually, than these acute gastroenteritis guidelines. And these are also freely available online. The third question is, which pathogens should be considered and which tests will aid in organism identification? Let's start with the first half of that question. Which pathogens should be considered? Now, we in the laboratory, we don't think about all these things as much as the frontline healthcare provider does, but the person actually seeing the patient, requesting the specimen, needs to consider things like the patient's exposure history, how immunocompetent or immunocompromised the patient might be, and the clinical course of symptoms for the patient. The IDSA points out that when there is fever, when there's bloody diarrhea, severe pain, or signs of sepsis, then these organisms, these pathogens should specifically be considered. Salmonella, Shigella, Shigatoxin-producing E. coli or STEC, Campylobacter, Yersinia, and C. diff, with the caveat that C. diff is not expected to cause infections in which there's bloody stool. And as you remember, fever is going to be seen in about 20% of the time when norovirus is present, and a little more than half the time when Salmonella or Shigella is present. There's this nice table in the guidelines. If you are responsible for writing questions for med students or med tech students or residents, this is a good source to find information for your question stems for exposures. They point out, they break this up by foodborne, exposure or contact, and exposure or condition. So starting out at foodborne, here are just a couple examples. Some of these are classic, right? Don't be like Rocky, don't drink your raw eggs, or you might get Salmonella or Shigella. If you visit a petting zoo and have acute gastroenteritis, Shigatoxin-producing E. coli is near the top of the list, and also Campylobacter, Cryptosporidium. And there are other examples. For example, if someone travels to a resource-limited area, then there's a whole list of pathogens to consider, including a lot of parasites. If there's long-term healthcare exposure, then think about norovirus, C. diff, Shigella. If the patient's immunocompromised, consider Salmonella, Campylobacter, Cryptosporidium, and other agents. So these are all things that the frontline clinician needs to consider when ordering testing. Now, which tests will aid in organism identification? When antimicrobial susceptibility testing needs to be performed, for example, in patients that are immunocompromised with severe illness, or when public health needs an isolate for further testing, for example, for surveillance purposes, then culture should be performed either by the clinical laboratory or the public health laboratory. Now, how often is resistance a problem? This is just a couple of examples. So for Salmonella in the United States, less than 0.5% of isolates are resistant to ciprofloxacin. So Salmonella gastroenteritis typically is not treated with antibiotics, but if the patient's immunocompromised and the provider feels like it is necessary to treat the patient, there's very little resistance, for example, to ciprofloxacin. Shigella, along the same lines, has about a 2.5% resistance rate to ciprofloxacin. And this is all, these data are all available through the CDC. You can see in their NARMS database. So getting back to which tests will aid in the organism identification, when bacteremia is suspected, and remember they mentioned if a patient has gastroenteritis and fever, that bacteremia might be present, or if somebody has sepsis or is an immunocompromised individual, this would also be a reason to look for bacteremia. And the guidelines state that culture-independent, including panel-based molecular diagnostics from stool and blood specimens, when indicated, culture-dependent diagnostic testing should be performed when there's clinical suspicion of enteric fever, which we rarely see in the U.S., thankfully, or diarrhea with bacteremia, which would be more common in the U.S. And that recommendation is a strong recommendation with moderate quality of evidence. And they mention the caveat that we need to remember that molecular assays detect DNA and not necessarily live organisms. So in summary, which pathogens should be considered and which tests will aid in organism identification? Pathogens to consider depend on the patient's exposure history, their signs and symptoms, and their immune status. There can be a role for many test methodologies, including testing stool with panel-based molecular assays. This is in the very last paragraph of the paper, and I think it's a telling statement. A key challenge in the diagnosis and management of people with infectious diarrhea is the use and interpretation of molecular-based diagnostics. Differentiating colonization from active infection, obtaining antimicrobial susceptibility results, providing optimal management, and preventing transmission are areas in need of additional research as non-culture diagnostics replace traditional culture-based methods. I found it interesting that they see, or I infer from this, that they see non-culture-based diagnostic testing as the future, at least in gastroenteritis. As they mentioned that it's replacing traditional culture-based methods. I just have a couple slides looking to the future. I always like thinking and learning about new diagnostic tests. And 10 years ago, a platform like Verogen and would be a little bit pie in the sky. We could imagine it happening, but not anytime soon. Well, it's here now, and what's the next step? What's the next thing that could happen that would radically change our testing in the micro lab? This paper was published, it was written by a group at the FDA, and they talk about establishing genotypic cutoff values to measure antimicrobial resistance in Salmonella. They did a lot of work. They sequenced whole genomes of over 1,700 Salmonella strains and correlated that with 20,000 data points of MIC data. And this is just one of the many tables in their paper, but this gets the point across of what they're trying to do and how they can do it. They did this with whole genome sequencing, but it's not far-fetched to imagine doing this straight from a specimen using metagenomic testing. So in the top left corner, you can see these are above the line, the 0.06, 0.03. These are low MICs that would be interpreted as susceptible to ciprofloxacin. And they're on the most left-hand column where when they sequenced the whole genome, they did not detect any genotypic mechanism of resistance to ciprofloxacin. That's in contrast to the lower right quadrant where you can see that they either detected a QNR gene or a mutation in a gyrase gene, and all of these had phenotypic evidence of resistance. As you can see, their MICs were 0.12 or higher for ciprofloxacin. So I think it's very interesting that at least for some bug-drug combinations, a genotype might be able to provide susceptibility information that's on par with phenotypic data in the future. So on the left is what we used to do, on the right is what we do today, and like I said, our infection control practitioners are excited that we can identify norovirus. As I mentioned, 8% of our specimens this season were positive for norovirus. And we also like the rapid turnaround time and feel like that's a better service that we can provide to clinicians where we can report out results the same day instead of waiting a couple days for cultures. So that's the end of my presentation. I'm going to hand it back to Bob.
Dr. Rhoads, thank you so much for such a wonderful presentation. Very comprehensive, very, very interesting to see the before and after results in the diagnostics in your labs after the adoption of Verogen. Fascinating. Let me remind our audience that at any time they can write questions and comments in the Q&A box underneath our slides. And we'll answer as many questions as we can in today's webinar. Now, after thanking Dr. Rhoads for such a great presentation, it's a particular pleasure for me to introduce our second speaker. Dr. Jose Alexander received his medical degree through his work with the Public Health Department of Venezuela. He's a diplomat of the American Board of Medical Microbiology and enjoys certification through the ASCP as a specialist in microbiology and molecular biology. He's a medical and public health microbiologist at the Florida Hospital, where he's also a microbiology manager. And it's a great pleasure to have Dr. Alexander now present for us. Dr. Alexander.
Yeah, well, thank you very much. I'm not able to see my slide right now, but I think I'm able to change the slide, right?
Yes, anytime you would like me to, I'm happy to change the slides for you, sir.
Yes. Okay. Thank you for the opportunity, and I think this is a very interesting and important topic to discuss. I think every laboratory in the U.S. have to face this decision anytime soon. I think molecular diagnostics coming to microbiology in the last few years faster than any time before. Stool culture, moving from the stool to a molecular platform, seems to be the next big step for many laboratories, not only for the improvement of the technique for detection of pathogen and the benefits on the patient, but also the benefits for the laboratory itself. So we can go to the second slide, just to give you a little background about Florida Hospital. It's a 2,400 beds system with 7 hospital and multiple long-term and nursing home facility. Going to the third slide, the Microbiology Department is centralized. We have a flagship hospital in Orlando. We operate multiple sub-departments, and we have a staff of 42 full-time med techs and operate 24/7. Going to the next slide, and just basic information about the department. By last year, we have 780,000 tests performed only in the microbiology department, with 7,200 stool culture. So norovirus and rotavirus also are 2 of the tests that we plan to perform in this in the molecular platform, and the specimen volume could be around 1,500 and 800 samples. We go to the next slide. We can see that we have multiple molecular platforms. So the basic platform in our facility for multiplex was the Virgin. So we use for gram-positive panel, and we are in the process to finally offer the gram-negative panel on our hospital menu. But in the same time, the enteric pathogen is right now we're just finishing the validation process. We also have the gene expert Infinity with multiple assays that we perform 24/7. To continue to the next slide, we can see the basic question that many of the laboratory is actually asking now is, do we really need to switch from stool culture to PCR panel? So there is some advantage to switch into a molecular platform. One is the stool are technically challenging. Everyone working on the bench know that we have different, there's some different option to work in a stool culture bench, but one of the most important is, we use a special media and we spend days isolating individual colony until we found enteric pathogen, or we invest more money and use more resources and do identification in every suspected colony. So in the end, it's a culture that is very relied on the technical expertise of the operator on the bench. Also, those results are actually reliable. It's time-consuming. Turnaround time could be around 5 days or even longer. The culture depends on the organism viability, and the susceptibility sometimes is not actually required. So in the next slide, this is the information that we use for making the case in 2017. We use based on the total volume on the department for the different assays or different organisms that we was planning to screen from a stool sample, including norovirus and rotavirus. In the next slide, we can see that the total number of organisms that we during making the case, one of the important steps for us was to go back and look what is the incidence and prevalence of some of the organisms that we actually are able to screen and look in the stool culture. Salmonella has the highest prevalence in our institution. The second one was Campylobacter, but each of them has a very important amount based on from the stool culture. but we still feel like the stool culture are not actually detecting the amount of organisms that we are seeing circulating in our population. If we go to the next slide, we can see that the distribution of the pathogen actually matched with the CDC FoodNet reporting during the last few years, Salmonella and Campylobacter being the most prevalent. Going to the next slide, we can see that one of the advantages to move the stool sample from culture to PCR was being able to redistribute the benches, redistribute the staff, improve the turnaround time from 5 days to 24 hours, and even we can go even lower than 24 hours to talk about 12 or even 6 hours. Can increase the sensitivity of detection, and we can improve in-house viral detection, moving from EIA or any other non-molecular platform to a molecular platform. Going to another slide, we can also have more space on the ambient incubator. What laboratory right now doesn't really need a space to maybe to increase the incubation of some specific culture that actually can be beneficial for some specific culture or source. So we can reduce the amount of purchase that we have for multiple spatial media. We still will keep those spatial media in-house because we have planned for culturing some of the organisms detected, but also for any other source. We can screen routinely for Vibrio and Yersinia, something that we right now have a separate order as recommended for some of the guidelines. But the most important thing is we can screen for Shiga toxin genes that are able to detect for non-0157. That's the only genotype, the only group that we are able to detect right now in the laboratory, in the clinical laboratory, but also non-toxin producing Shiga toxin E. coli. And I think this is an important point, the data that I will show in different slides. So if we go into the next slide, the IDSA guidelines. We are in the next slide, right? The one with the IDSA practice guideline?
Yes, sir.
Okay. Yeah, just make sure that we are on the same page.
Yes,
the guidelines is something that we actually came in a specific time for us. We was working to bring molecular platform, and the guideline actually support switching from a stool culture method to a molecular platform, but also have very interesting indication and what are the pathogen more that are kind of required for to be screened routinely. So in the next slide, we can see that culture-independent methods now are recommended. Different scenarios can be also created, and one of the advantages of the molecular, or one of the points that we want to make sure is that the clinical manifestation of the disease and epidemiological information match with the order required for the patient. So dividing panels between bacterial, parasite, even viral panel and C. diff is very important. So that technically is something that we use in C. diff. Ideal samples take the shape of the container, but the ideal sample for all of those panels need to take the shape of the container based on the clinical manifestation and the epidemiological information. So in the next slide, there is 3 points important on the IDSA, and one of them was key for us was screening for detection of Shiga toxin or genes to distinguish 0157 for non-0157 stool is recommended. And this is the important point, since many non-0157 or low-level producing or non-producing toxin, Shiga toxin E. coli, are not going to be detected by routine culture, even when the gene is present. So that's one of the advantages of the molecular platform. If we go to the next slide, this was one of the biggest questions that we have. We go to the BioFire or we go into the VeriGene. We have both platforms in-house. BioFire is used for a sub-department in virology, and the VeriGene is using more in the blood culture section of the Microbiology Department. So one of the advantages of the VeriGene for us that we're going to see in the next slide, what is distribution of the targets. So many of the targets indicated in the IDSA guidelines are included in the Verigene. So the BioFire has multiple other and also have a very interesting group of targets that for parasites, but also include Clostridium difficile. So one of the advantages that we found in the Verigene is able to custom to create custom panels. We are able to create sub-panel from bacteria or only viral panel. So C. diff for us wasn't really a concern because we have a different molecular platform and a completely different protocol for C. diff that we are not included in the stool panel. And also the parasite, they have a completely different clinical manifestation and epidemiological background that is important to bring in consideration. So routinely test for parasite in patients that doesn't have epidemiological indication could be probably not adequate in many of the patients. So choosing the PCR, the Verigene, we have at that time 4 processors, 1 reader. We increased to 2 reader and 8 processors. We are able now to create 2 sub-panels. One will be a bacterial panel and one will be a viral panel. We are not going to test viral we are not going to screen for viral infection routinely in every patient, but if physician want to order both panel, is able to do it. So, but what about Aeromonas and Plesiomonas? So we only detect 2 or 4 Plesiomonas in 2016 from all the positive stool culture, and we didn't detect any Aeromonas. So for us, those 2 organisms are not going to be a concern, but we still want to be able to offer a custom stool culture in case based on previous consultation with the micro department. And do we need parasite panel? Well, the same thing. Parasite panel, the clinical indication and the epidemiological background could be a little bit different. So the next slide, we have one of the decisions that we went to review in the stool culture in 2016 was we only have 4.2% of the prevalence of enteric pathogen. We perform 567 stool culture per month. That is around 20 culture per day. If we also include norovirus and rotavirus, we're talking about around 30 samples per day. We only have 2 Plesiomonas shigelloides, and we didn't have any Aeromonas. So the next slide, we can see that the IDSA Clostridium difficile guideline also came in a good moment for us. Just came to support if we go to the slide, we are on the slide after the, yeah, that was right, perfect. So, very good. Okay, that you can see that one of the recommendation is if we don't have a good clinical screening for patient to order Clostridium difficile testing, the double-step test probably will be the best recommendation. For in our institution, we have double-step. We use GDH and toxin, and discrepancy are solved using a PCR platform. It's a completely different platform than the Verigene. So, and this is something that we are already implementing in the institution, and we continue to be performing in that direction. So it's up to the facility or the hospital and communication between the lab, infection prevention, and the physician if a direct molecular test will be recommended or is the best solution for the C. diff problem in your institution. So in the next slide, we can see the cost. So when we went digging into the cost of the culture, we get a big surprise that almost $28 was only the set of the stool culture, considering special media, GM broth, some of the Vitek ID card that we use for identification, and the Shiga toxin EIA. And the operation for culture, we did a review of the amount of work that the bench was performing in the stool, and we get a total of 35 minutes 5 minutes setup time, and 30 minutes per culture during 5 days. So in total, we get an average of almost $53. The whole stool culture, considering the supplies, the reagents, and the hands-on time of the staff in this time. So this total amount, if we go into the next slide, that was compared with the Luminex price that we have, and the difference was really not insignificant for us. But one of the biggest advantage was that we don't need the processing that we have right now for a stool. So we are talking about removing around 20-25 culture from the daily work, and we also now we can assign the whole amount, the whole volume to the molecular bench. That when the hands-on time is only less than 5 minutes per sample. So we are able to reduce the amount of hours, staff hours, from 35 to only 5 minutes. So why diverging? In the next slide, we can see that the platform was already in-house. We're able to customize individual target or create sub-panels. CDIF is not included in the panel. It's something that for us make a little bit easier the implementation, since we already have this in a different platform. And with no parasite panel and include, we are going to deal with the parasite in a completely different scenario. So we want to make sure that the patient, the clinical presentation, and the epidemiological are considered before to use a parasite testing. So in the next slide, so how we validate the panel. So we can see in this slide that the validation protocol that we implement was based on positive and negative samples. We also use known positive and negative frozen samples and QC material. In total, we use 48 known positive and 10 negative samples. It's very important to notice here that this is a multiplex panel. So this is a panel that has 9 different targets. So we use positive sample, they only are positive for one target. So that means that every time that you run the sample, you have one positive target detected, but you also have 8 negative samples, negative targets. If you put all of them and validate the whole panel, including the 9 targets, for every positive sample that you run, you will have 384 negative. So and this is something to put in perspective, because with only 48 positive single targets, every test that run with a positive target, you also will have a negative that can be used in your validation protocol. So in the next slide, we see the distribution of the positive targets. We have, in this case, 6. We use 6 specific organism or targets for the entire validation protocol. So in the next slide, like all FDA-approved platform, we perform sensitivity and specificity. We calculate sensitivity and specificity, reproducibility, and precision. All validation is just finished a few days ago. We have 100% sensitivity and specificity. All the targets were detected as expected. So the next slide is how we want to be distributing the panel. So we want to create 4 different targets, 4 different panels. One for bacteria, one for viral panel that include rotavirus and norovirus, and also rotavirus and norovirus will be ordered separately as a single target. And this is for requests on infection prevention. Sometimes we have patients that have norovirus in the hospital, and if they wanted to do a point contact screening, or they have another patient that have diarrhea after 3 days of hospitalization, and the patient have been in contact or close to a patient with norovirus, they want to make sure that they always is able to order that single target. So the operator will be responsible for setting the instrument and the moment that the test is set up. We are creating customized culture for organisms that are not including the target, and the yeast culture and the VRE screening, they should be ordered separate. It's very common in physician requesting to the laboratory to report any VRE or yeast detected on the plate. Stool culture should be for enteric pathogens. So yeast culture and VRE screening culture could be offered as a separate culture for those specific organisms using a specific media. So in the next slide, we can see the algorithm that we were planning to work with. So the algorithm is based on a stool bacterial panel. When we have a negative result, the test will stop. With testing will stop, we are not going to continue doing anything additional. When we have a positive for Salmonella, Shigella, Vibrio, or Yersinia enterocolitica, we're going to create a custom culture. The custom culture will be only using the specific media for the specific organism detected on the PCR. And that will be for full identification. That will be play of the quality assurance of the instrument, but also susceptibility testing, and to submit the isolate for the state lab. And this is a very important topic. Moving from culture to molecular platform can have a negative impact if we stop collaborating with the public health department. So it is very important that you have in communication with them and they know that you plan to move from a different platform. They can assist you and they can help you, and you can create a whole protocol together, how to continue providing those isolates that are very important for epidemiological information. So that's why we set up the panel in this way. For Zika toxin 1 and 2, we want to have a custom culture that will be able to identify O157 and non-O157 through a Chromagar plate, and also submitting that to the state lab. For Campylobacter, we don't have any plan to do any culturing, but if this is something that show up with the state lab or something that we need to do additional, we want to be able to do it. And another point important here is we create every year antibiogram for the most common O isolate and in different sources, and the most common isolate in the hospital or different facilities. We went back to the previous 2 years and created a specific antibiogram for only enteric pathogens. So we are, since the PCR come positive maybe 2 or 3 days before the culture full ID and susceptibility, this information is being used to be indicated on the report. So the physician, when they have a Salmonella and Shigella, they will be having access to the previous 2 years antibiogram for that specific organism. So waiting for susceptibility is always indicated in some specific cases, but having that background data will help the physician to decide if they need or not treat the patient and which antibiotic to decide. So I think it's a good idea to go back data in your system, LIS, and trying to get a specific antibiogram for those organisms included in the panel. But again, I just want to make sure that working with the public health department is very, very important when you bring in this kind of testing house. So next, this is just a review for the data when I used to work in Marin General Hospital in Northern California. This is a hospital that have include a Kenfield Rehabilitation Hospital, and in total there was around 150 beds. So, and the interesting thing, the next slide, you can see on the graph that when we move from a culture method to a molecular method, the Campylobacter was the one that has almost 4 times the amount of the isolate that we detect the previous year by culture. Shigella also increased. We detect the first and only Yersinia enterocolitica. Vibrio also increased a little bit, but the most interesting data came from the Zika toxin. If we go into the next slide, this is the distribution in the Zika toxin that was detected, the gene, based on the antigen that was detected on the culture. So this is data from the Public Health Department in Marin County. So the important thing here is that 6 of the all Zika toxin detected by PCR do not react with any antigen O. So that means that in our facility, or right now using a culture-based method, we only are able to identify O157. So O26 or none or any of the antigens O were detected. So we're talking about 12 isolates that we were not able to detect by any antigen method that we have in our laboratory. If we go for the next slide, this is the production of Zika toxin. So 9 of all the Zika toxin that we were able to detect by PCR, they didn't produce any toxin. So this is data that can create a lot of false negatives if we only base our method for a stool culture, for a stool based on culture method only. So detection of antigen O and the production of toxin limited only to 157, or the toxin being produced can be very limited, and we can also be reporting false negative. So in the next slide is an indication for communication with providers. And I think this is important. When this test is coming in-house, communicate with your providers. Outpatient plays a huge role with this test. So report advantage and limitation of the testing. Trying to give it a lot of information for report and result interpretation. This could be maybe new for them, seeing only Shigella species. Make sure that in the comment or the description of the test, you are able to place all the species that are included in the panel that are not reported by species, only by genus, but they are also screened. Give an interpretation for Zika toxin. Say only Zika toxin 1 or 2 probably is It's not really the best method to do it. We reported enterohemorrhagic E. coli. We say that it's an EHEC. But we mentioned that Shiga toxin 1, 2, or both were detected. So mention the clinical presentation as an EHEC probably would be a better clinical interpretation for the physician. And make the lab requirement clear for specimen collection and transport. Kerry Blair is the recommended method we already use for stool culture, so it's not going to be a big change. But make sure the physician are able to know that what different tests can be performed for stool and what media or transport media can be used and which one are not recommended for what method. So I think the communication is very important. So in the next slide is one of the examples for our previous report. And the description could be long. It's true, it's a long comment, but the physician doesn't have to read it immediately. Every time that they see it, sometimes they will see it and they will read it. So putting that information there, we allow the physician to anytime be able to read it. They're not going to read it every day, or maybe not the first time, but some moment will read it. But they have all the information that they need to know about the target, limitation, and the specificity of the test. Now you will go for the next slide. Communication is important to provide it. What exactly is a stool culture? What is a stool by PCR? What is the benefit and the disadvantage of the method? What is the organism being able to do, and what do you do with positive and negative result? Don't let the physician wait for something coming when there is nothing else that will be reported. So let them know that after a positive Campylobacter, nothing else will be performed, or when they have a positive Shiga toxin, further identification and sending to the public health department will be performed. So the typical question is how many samples we are going to be able to accept. Well, we plan to only accept one sample. We are not planning to require multiple samples to be submitted to the laboratory. We're still trying to talk with infection prevention and ID group to trying to see when will be acceptable to receive a second sample. Can this test be performed in stat? For the ED, that probably will be the biggest question. When they know that you have a rapid identification method and the result can be back for enteric pathogen when the patient is still in the ED, something that will be requiring. We have a 24 hours turnaround time, but we plan to go down maybe to 6 hours or even less. So this is something that we're going to be evaluating when the test is finally live. Should the targets be separate or by group? We don't think that the bacterial target should be offered separate. We should be just a bacterial target, just like we do with the culture. The viral targets could be maybe a little bit different. Should be bacterial, viral, and parasite target performed all at once. The same thing. Parasite have a different condition for epidemiological purpose. So I think that's something that your facility with infection prevention and ID group should be considered, especially with the outpatient providers. How to interpret Shiga toxin detection. Reporting Shiga toxin 1 or 2 only could be maybe the solution for right now, but maybe given a little more clinical interpretation as a EHEC probably would be a little more useful for many of your providers. So what to do with a positive result? I think the best thing is make sure that you work with the public health department. You are able to enter information about susceptibility if you have previous data, at least as empirical treatment, or if the physician need that information. But at the same time, being able to identify and submit to the public health department, and it's part also to your quality assurance process for the system. Would it be necessary to continue with a limited stool culture? We are not going to offer a stool culture for the physician to be able to order anymore. The laboratory will have the opportunity to order if physician communicate with us and the case is discussed before to decide when to order. But the test for a single or standalone stool culture won't be available. And that's the final of my presentation.
Dr. Alexander, thank you very, very much. That was a wonderful presentation. I want to thank both you, of course, and Dr. Rhoads. And now we'll let each of you catch your breath. We do have some questions and comments from the audience. We'll deal with as many as we possibly can. We have received multiple questions regarding reimbursement, insurance denials, etc. The speakers and I both, in leading up to today's webinar, felt that this was a topic that we didn't want to treat in a cursory fashion in question and answer because it's so complex and there's so many different ramifications. So we're planning at least to defer this question now for today's Q&A discussion because we have so many others to get to. But we know that your Luminex representatives are very well versed in these issues and can be of great help. Also at CAP today, we're very happy to deal with any Q&A questions that you might send to us, and we'll do our very best to have experts answer the questions regarding reimbursement for some of these panels. And now I'd like to begin by asking both of our speakers a question. I'm going to begin with you, Dr. Rhoads. Has molecular diagnostics completely replaced stool culture at your hospital, or do you still offer traditional stool culture upon special request? And then in following, do you perform any susceptibility testing on stool pathogens, such as Salmonella and Shigella?
Sure. So we maintain our competency currently in stool cultures, but we don't offer it. If I don't know that any physician has insisted on a stool culture over the pathogen panel, but if they would, we decided that we would offer it as a send-out test. For some reason they really feel like they need a culture, we can provide it to them as a send-out to a reference laboratory. I believe there was only one this winter, one case where susceptibility testing was requested on a pathogen because they felt like treatment was needed. And in that case, we cultured the organism. It was a Yersinia, and we performed susceptibility testing. Some places require follow-up cultures for example, negative cultures for Salmonella and Shigella to demonstrate that their patient is no longer carrying the organism. And we do offer a follow-up Salmonella Shigella rule-out culture after a positive PCR.
Very good. Thank you. And to Dr. Alexander, would you like to make a comment and answer the same question for me?
Well, we are not going to offer a stool culture on available for physician to be able to order for the CPOE site. We're going to have the stool culture available, previous consultation with the department. If a basic enteric pathogen that are able to be detected by the instrument for the platform is the requirement, we're going to run the test in the platform. I know the Department of Health, sometimes they require that to clear a patient that was previous positive for Shigella Salmonella, they need to have negative culture. That's maybe a different scenario that is maybe more about epidemiological purpose. So that's something that we don't see, maybe something that we're going to do routinely, and that's something that we're going to be in communication with them. But we don't have any plan to offer the stool or have the stool open along with the molecular platform.
Thank you. And just as a follow-up from another attendee along the same lines, how do you handle positive PCR results for these two organisms when the MICs are requested and yet you find yourself unable to recover the organism in culture? First to you, Dr. Rhoads.
Yeah, so like I mentioned previously, we've only done this once upon request so far. So it hasn't happened yet where we haven't been able to recover something that we're looking for and that the PCR said was there. I think we'd be further ahead than we would if we only did culture, because if we only did culture, we wouldn't even have a positive result. Now, one could argue whether or not the molecular result is the true positive or the negative culture is the true negative, and that's a hard question to answer. All the time, that's a hard question to answer.
Yes, of course it is.
If we are concerned that it's a false positive, we can always repeat the nucleic acid test, make sure that it repeats and we get the same result, and that would help to provide some reassurance.
Very good. And Dr. Alexander, could you also comment briefly on this follow-up question?
Yeah, I think one of the interesting point is something that we are doing is we're trying to go to previous year data and create antibiogram for this organism and be able to place that information in the molecular report. I think that could be information for treatment in case a physician require, and we can reduce the amount of requests for susceptibility testing. We have opportunity that organism that was detected by PCR, especially Shigella, that were not able to be recovered. So one thing that we create was a specific comment that the organism was detected but not viable for culture. So based on our validation protocol that the instrument performed very well for Shigella, this is probably the most common cases that organisms are not being able to be grow on culture, but what the DNA was detected in PCR. So I think moving from stool, the culture to molecular, I think that's something that have to be considered. Be able to know that that is a report that sometimes have to go if you plan to do a reflex on the molecular to culture.
Thank you very much. I was very pleased to see that our friend Judy Lisak joined us as a participant in today's webinar, and she's asked an excellent question, and I'd like to ask Judy's question of both of you now. First, I'll lead again with Dr. Rhoads. How do your clinicians handle treatment decisions when multiple pathogens are detected in your panel runs?
Yeah, that's a good question, but in practice it happens very rarely. Maybe a couple times or a few at most we've had multiple targets hit. For most of these pathogens, even though they're causing disease, the recommendations are not to use any kind of antimicrobial therapy for treatment, so the treatment typically doesn't change. It's still supportive without any targeted therapy. From the lab's perspective, if we have multiple targets hit on a single specimen, we repeat it to make sure that it's both targets hit again and that it's a true positive on both or multiple targets.
So very good, thank you. And Dr. Alexander, the same question.
So the two opportunities that we have was Salmonella with Shiga toxin 1 that was detected on the same patient. There was a 25-year-old man, and if I recall, the physician didn't actually treat the patient. The second opportunity was a Campylobacter with a Salmonella. In this case, the patient was treated. I think in those situations, the physician never requests any additional susceptibility. The patient was treated successfully. I think was with ciprofloxacin. But we haven't seen multiple targets being detected, at least bacterial targets. We haven't also get requests for every specific susceptibility.
Thank you. We have another friend who attended today, Dr. Ella Roth, a very distinguished pathologist who's been a long-time friend, and I want to ask his question of both of you because it's a quite interesting one. What, in your opinion, is the role of the gut microbiome in the susceptibility of diarrheal diseases? Do you regard the regular ingestion of beneficial bacteria, as in certain diet aids, to be useful in this prevention? I'll lead with you first, Dr. Alexander. Do you have an opinion on this?
Well, I think this is a very interesting question, actually. I think most of the organisms that we're dealing as enteropathogen using this platform, they are non-normal flora. And we know how disruptive they can be when they colonize part of patient and start creating diseases. Antibiotics still seems to be the gold standard in some specific case, but in other cases, and many of them, actually antibiotics are not required. So that indicates that the normal flora actually play a huge role being able to eliminate this organism from the environment. So I can see that in the future, reinforcing the flora could be part of the treatment, of indication for treatment for many of these organisms. Since we already see them, especially in adult health patients, where antibiotics is actually not required, and maybe many of these diseases are auto-limited.
Thank you very much. And Dr. Rhoads, I'm going to give you a chance at this same question here.
Yeah, I think the microbiome research is very interesting, and clinical microbiology used to be microbiology of infectious diseases, but I think now it's moving, or we can see it moving towards not just microbiology of infectious diseases, but microbiology of health and disease. And we recognize that the microbiome plays an important role in our health, but it's hard to say exactly, get more granular than that a lot of times. You know, I think C. diff, in C. diff, it's clear that the normal gut microbiome is essential for, holding off C. diff from causing disease. But I'm not aware of other infections and the role of the normal microbiome in preventing disease, although, it makes sense, scientifically or theoretically.
Thank you. And we'll go from way into the future into something that's a current concern with one more question, and I'll ask Dr. Alexander to start. Do you have any criteria to reject a stool culture that is formed? Currently, at this participant's hospital, they accept all stool specimens, regardless of their appearance and presentation for culture. Dr. Alexander?
Well, I never see the first case of diarrhea with formed stool. So I think that is something that can be a little, I think that would be easier to argue about to stop sending those samples that doesn't have requirement. For C. diff, we receive a sterile container, so we need to have the specimen to be formed, take the shape of the container. For this particular test, we receive the specimen in Kerry-Blair. One of the limitations, one of the problems with that is you don't have the specimen, the full specimen without the preservative. And I think that could be a little difficult to argue about if the specimen is formed or is not formed. In many situations, we are able to see the specimen was actually was not formed when it was placed in the Kerry-Blair. I think that in our institution we actually enforce that very strictly. We don't receive any non-formed stool in sterile container. In the Kerry-Blair, that's something that is difficult to argue since the specimen is come in a liquid preservative.
Thank you very much. And Dr. Rhoads, could you also comment on that question of criteria that might lead you to reject a stool specimen? Or do you indeed adhere very closely to the guidelines that you mentioned?
Yeah, we require diarrheal specimens, so formed stool would be rejected. We always invite providers to reach out to the, microbiology medical directors if they have concerns or they think that their patient is an exception. But in standard of care, we only test diarrheal specimens.
Very good. Thank you very, very much. And with that, I think I'm going to bring our webinar largely to a close. We have a great many questions, of which we're going to gather all of them, and you'll have them answered in due course one way or another through our sponsors, and also I'm sure our presenters would be happy to help at a future date with some of these many questions. I know that everyone is very busy, and so I don't want to overstay our welcome. But I do particularly obviously wish to thank Luminex. They've made this webinar possible through their special educational grant, and we're very, very grateful to them. It wouldn't be possible without them. And in particular, of course, I want to thank Dr. Daniel Rhoads and Dr. Jose Alexander. They both gave wonderful, rich and full presentations. You'll be able to access their slides and their audio at captodayonline.com in about 5 to 7 days. Finally, I want to thank all of you who've taken time to participate in today's webinar. We're very, very grateful that we have such full and rich attendance to these events, and we love the questions and comments. So finally, our thanks to all of you. And with that, thanks again to all. I wish you a very good day, and I'll now bring this webinar to a close.